to move forward, I'm just going to introduce our next speaker, which is Dr. Oliver Stovin and Charlene Tang from Cytosponge, and they're going to talk about how this might be useful in primary care. Can I hand over to you, Dr. Stovin?
Yeah, that's great. Can you hear me?
Yes.
Great. Can we go to the next slide then? So basically, I want to just run through things. I mean, esophageal cancer, as probably people know, there's 9,200 cases per year, 20% 1 year survival all round. But if it's detected at stage 1, you get a 55% survival to 5 years. So something that we could definitely improve with early diagnosis. Next slide. So so Cytosponge, for those who don't know, is basically a small capsule with a sponge inside. You swallow it, the capsule dissolves, and the sponge, which I liken a bit to a sort of scouring pad, is by then in the stomach, and it's pulled back. Takes about 10 minutes to do. It captures cells which are then analysed. Rightly or wrongly, I look at it as very similar to a cervical smear in the past before HPV was done. So we were looking for cells, we're looking for dysplasia and so on. Next slide. So it's been around for quite a while, developed principally in Cambridge by Prof. Fitzgerald. There's quite a lot of evidence, particularly in respect of tolerability. Actually, it's specificity and sensitivity, also some of the outcomes of increased picking up of Barrett's esophagus, a precursor of esophageal cancer, compared to normal practice, and there have been health economic ones, so I don't want to particularly go into them now. Next slide. So, I mean, at the moment, only less than 10% of people with Barrett's, which predisposes to adenocarcinoma of the esophagus, which is the commonest one, only 10% are actually diagnosed. Obviously, health inequalities is high on the agenda, and it's something that can be delivered outside hospitals and closer to home, so potentially is very good for addressing inequalities. And long term, I think with evidence, it will be an alternative to an endoscopy, so can reduce pressure on scarce resources. So next slide. So we've got a picture of me, unfortunately, but basically I was a GP, semi-rural. Always I got involved with PCTs and CCGs, and mainly with respect to pathways. And the last 6 years after retiring from general practice, I was cancer lead. So that's how I've ended up being involved with this. Next slide. So where Cytosponge is being used at the moment, and the one that I'm mainly involved with, is targeted screening, where we're either identifying patients that are on a chronic PPI who've never really been investigated. So if you take Cambridge and Peterborough CCG, we've got a population of 1 million. We identified 75,000 plus patients on a regular PPI, and probably at least a quarter of them have never had any investigations to see. They're just happy getting their PPI, having their symptoms relieved, but we've no idea how at risk they are. We've also started doing symptomatic testing pre-referrals, so almost on a par with doing a fit test for colorectal cancer, a useful, quick and easy test to triage within primary care. In secondary care, we've got symptomatic testing, so part of Delta, they're testing patients that are referred to help triage them. And Barrett surveillance has been taken up, and I know UCL have adopted it, I think, as their standard practice now. Next slide. So actually, if you go back, sorry, yeah. So the ones that we're screening in primary care, we've got funding for a 3 sites where we've got a mobile unit that is sitting in different sites, where we are offering about 12 tests a day, and we've got general practice producing a list of patients that have been invited. General practice only has to effectively produce the list and support them. They're then invited for a Cytosponge. We've found that our searches are sufficiently well powered that of the people that we're selecting, almost all of them are appropriate, and the triaging is straightforward. We're also inviting with posters a number of people who are self-medicating. One of the things that I noticed was that you can buy 14 esomeprazole for about 11 quid. And I also noticed some supermarkets offer 2 for 1 occasionally, so you can actually get a month's supply for 11 quid. And we don't quite know how many people are self-medicating, but certainly the head of Heartburn Cancer UK, who has part funded our pilots, her husband self-medicated at something like 48. He suddenly developed dysphagia and he was dead 9 weeks later. So she is very passionate about this group of self-medicators that really are well below the radar. So next slide. So bottom left, you can see the research bit that we are doing, and the other information as to what's going on elsewhere. Next slide. This is something that we are working on and would love people to get involved. Next slide. So from the primary care point of view, we've had quite a lot of learning from what we've been doing with respect to the citing of it, with respect to the searches, triaging. So by the time we've finished our pilots, we will have looked at citing it actually at a surgery, citing it at a sports centre, citing it at a community hospital, working out how we engage with patients who are self-medicators. At the moment, the adverts are producing far too many people who are inappropriate. The self-referrals often include people who are wanting a second opinion, who are waiting for investigations and feel that they'll get fast-tracked, which is not what we're asking for. I've had a lot of interest locally in the east of England about this. The biggest problem is still the funding, but obviously alliances have money. There are, as has been mentioned, there's lots of different sources of money, and we're keen to support anyone who can take this forward. And ultimately, I think it will be something that is adopted in most areas. Next slide. So at the moment, we're involved with the triaging is all being done by nurses. We're exploring whether this can be done entirely by admin with a protocol, particularly as most of the ones that are invited actually don't have any problems. It may be the self-referrers are still ones that are have to go through a nurse. Next slide. Our sort of vision for the future is, if you look at the top left, this is where we are at the moment, with a significant number of endoscopies, very low diagnosis of Barrett's, and lots of people at late stage. Going forward, we do lots more Cytosponge tests. We still do a lot of endoscopies, but because they're more targeted and we've selected patients, we actually are diagnosing much more Barrett's, and because we're having Barrett's diagnosed and doing surveillance, we're actually picking up pre-malignant conditions and early cancers and diagnosing people earlier. Next slide. So this is really just sort of asking for interest and hoping to to take this forward. The other thing that's coming along is in conjunction with King's and Cambridge University, we've put in a bid for a large study, hopefully starting next year, called Best 4, which will recruit up to 100,000 patients. The thoughts at the moment are that that would involve probably East Anglia and London, and that would provide enough patients to get the recruitment levels that we need. So again, we may well be coming to London asking for support. Next slide. So that's just a summary. So, I mean, I'm very passionate about it, and that it is good. I haven't had it done. We've got lots of YouTube clips of people having it done. We've got all the evidence, and we're happy to support anyone who's interested in taking it forward. Yeah.
Thank you, Dr. Stovin. That's great. Do we have any questions for Dr. Stovin and his team about Cytosponge? As you mentioned, they are looking for potential pilot sites. If it is something you're interested in, please do drop me an email or drop an email to the commercial team, and we can facilitate that going forward.